Okay, coming to our the third session, that is renal session. To this next month, that is day after tomorrow, February. February, you will have the mock test again on 28th, and we will do debriefing session on by 24, 25. Okay. So this is a regular event about the mock test, and I will expect that everybody should give the mock test and uh, and then attend the debriefing session. Otherwise, it is not a class for the preparing you. So when you are giving the mock test, at least you will prepare yourself which is required to pass the exam because it is a costly exam. So I don't want that you spend money without aim. Uh, okay. So coming to the subject, 65 years old gentleman presented emergency department with severe non-radiating thoracolumbar back pain that began 48 hours ago, rated 8 by 10 on the Spain scale. And his past medical history include essential hypertension diagnosed 12 years ago, hyperlipidemia managed with 8 years, and chronic degenerative disc disease causing permanent persistent back pain for 5 years, and arthritis of both knee. He take hydrochlorothiazide 25 milligram once daily, atorvastatin 40 milligram at bedtime, ibuprofen 400 milligram 3 times daily as needed, and recently started Remipril 5 milligram once daily 3 weeks ago for better blood pressure control. The gentleman admit to taking additional dose of ibuprofen approximately 2400 milligram total daily over past 48 hours for worsening back pain. So you are understanding by the time that patient might develop the nephropathy. He also mentioned reduced urinary output despite continuous his regular dose of hydrochlorothiazide. He denied any fever, chest pain, or neurological symptom. On examination, his blood pressure is 95 by 54 mmHg, heart rate 12 beat per minute, respiratory rate is 19 breath per minute, oxygen saturation 97% on the room air, temperature is 99.1 degree Fahrenheit. His mucous membrane appear dry. He has decreased skin turgor. Cardiovascular examination revealed normal heart sound without murmur. Chest examination so clear breath sound bilaterally. Abdominal examination is unremarkable. Okay. So low urine output, low BP, and the temperature is okay. So here the WBC count is normal, hemoglobin okay, hematocrit is okay, platelet also okay, serum sodium, potassium okay, chloride, bicarbonate is lower side, so acidosis is there. Barn urea nitrogen, barn is blood urea nitrogen is little high, creatinine is little high, anion gap is there, lactate is marginally high, troponin I is normal, serum creatinine kinase is high. So you are dealing with a renal failure case. So which of the following etiology acute kidney injury should be excluded first in the clinical scenario? Volume depleted with prerenal azotemia, contrast-induced nephropathy, there is no contrast. Acute interstitial nephritis, non-steroidal anti-inflammatory drug toxicity, and cardiovascular, cardio, sorry, cardiorenal syndrome. So it is a straight cut answer. Please give your answer on your chat box. This is the first time. Okay. So D is Aditya and Joydeep is B. Why contrast? Is there any clue given in the contrast? Let's see the question. So back pain, foreign needed recent remipil. Gentleman taking a buprofen. Here's the immune output. There is no history of doing any contrast imaging. Okay. So maybe the D will be the correct answer. Let's see. Volume depleted prerenal azotemia. Why? The option A, volume depleted prerenal azotemia is correct answer because prerenal azotemia represent most common readily reversible cause of acute kidney injury. The thing is that the hypotension was the clue for this answer because this is a hypotension. There is a this azotemia. Uh, yes. So this is about your azotemia and the laboratory findings support the prerenal azotemia elevated burn. Okay. Mild metabolic acidosis and importantly prerenal azotemia often rapidly reversible appropriate volume repletion and crucial. Why not is a contrast induced because there is no contrast. Acute interstitial nephritis, why not? The wild condition can be caused by non-steroidal anti-inflammatory is typically present with fever, rash, and eosinophilia if it is acute interstitial nephritis. Okay. And non-steroidal, why not non-steroidal anti, although non-steroidal anti-inflammatory toxicity contribute gentlemen acute kidney injury, primary mechanism through effect of renal autoregulation and non-steroidal anti-inflammatory toxicity typically present more severe metabolic acidosis include gastrointestinal symptom, altered mental status, which is not present here. Okay. Next question. So 31-year-old male by profession bodybuilder brought to emergency department after being trapped under debris of 6 hours following an earthquake. He has a history of anabolic steroid use, protein supplement consumption. His current medication include testosterone, enanthen 250 milligram intramuscularly weekly, oral stanozolol 40 milligram daily. He appeared confused, agitated, and physical examination revealed extensive crash injury for both lower extremities, significantly soft tissue damage, multiple displaced fracture in the tibia and fibula, bilaterally severe deep laceration. His blood pressure is 98 by 60, low BP. Heart rate is 115, respiratory rate is 22 with oxygen saturation 95% room air, temperature is 99. Assessment with sonography for trauma, first scan is negative. So, and the CT of head, chest, abdomen, so no acute finding. He's received 1000 ml of ringer lactate solution in the field. His urine output over past hour is 8 ml cola color urine and urinary dipstick positive for blood, but the microscopy show no red blood cell. So what is happening here? In your EDIC exam, the main clue of the answer will be in your question itself. So here patient suffering for crash injury followed by hypotension, low urine output means that it may be the rhabdomyolysis and the cola color urine, no blood cell means myoglobinuria may be the cause. Let's see hemoglobin 9.8, white cell 15.2, platelet count is 145, serum sodium 144, serum potassium 5.8, serum chloride 108, serum bicarbonate 18. So acidosis is there, urea, burn nitrogen high, serum creatinine little high, serum creatinine kinase is very high. So it says that it support the rhabdomyolysis. Myoglobin is high, so myoglobinuria is the cause. Calcium is okay. Potassium phosphate is high. So SGOT, SGPT is a little higher side. So which one of the following most appropriate next step of management? So here this is an indirect question that what is the commonest cause of rhabdomyolysis and what is the treatment for rhabdomyolysis. So here this is about your management of rhabdomyolysis. So rhabdomyolysis, one of the important topic. There are three type of question come from the rhabdomyolysis. One is regarding the management. Second is regarding the what electrolyte imbalance you may found in your in rhabdomyolysis, and third is the regarding the kidney injury, the pathophysiology of the kidney injury in rhabdomyolysis. These three type of question. So here correct the option is aggressive fluid resuscitation, admission of sodium bicarbonate, urinary alkalization, being continuous renal replacement therapy, administers intravenous furosemide, and start mannitol infusion. We'll discuss each and every option. So a large amount of aggressive fluid resuscitation is the answer because there is a tubular blockage occurs due to the myoglobin molecule, because myoglobin molecule is a big molecule and it forms the crystal which is caused the acute renal failure in a myoglobin in rhabdomyolysis. So you have to give the thrust. So it calls the you have to give the thrust big amount of the fluid, and you have to maintain the urine output at least more than 70 or more than 100 ml. Or if you go for the per kg body weight, it should be more than 1 ml per kg body weight for hourly urine output. And next is the your administration of sodium bicarbonate for urine alkalization is a second line of treatment. Second line of treatment to because it it has been shown that if you do alkalization of urine, there is a chance of high clearance of myoglobin, and alkalization of the urine is the treatment of choice when you are dealing with amphotericin poisoning. So being continuous renal dismantlement therapy not required regularly. So this patient having the low urine output first is need fluid resuscitation. Most of the time fluid resuscitation will improve the urine output. And so CRRT is not required, but some cases it need. So not is the next best step. And administration of intravenous furosemide loop diuresis should not be administered initial treatment of rhabdomyolysis. Yes, diuresis may needed, but it consider after fluid expansion, after giving the fluid resuscitation. And mannitol also work as a osmotic diuretic effect, but also carried the fluid depletion and acute kidney injury if dehydrated. You have given the drugs in a dehydrated state, so it is better to use any diuretics, any form of either osmotic or loop diuretics after proper fluid resuscitation. Now coming to your third question. Third question is, 41-year-old gentleman admitted with intensive care unit in altered mental status, profound weakness, hypotension, tachycardia, tachypnea, temperature is high. His past medical history include Crohn's disease, completed multiple bowel resection, resulting short bowel syndrome, enterocutaneous fistula, chronic malnutrition requiring long-term total parenteral nutrition. He is also steroid-dependent inflammatory arthritis. Take prednisolone 7.5 milligram per daily, mesalazine 1000 milligram 3 times daily, adalimumab 40 milligrams subcutaneously every 2 weeks. Shortly after admission, he developed generalized tonic-clonic seizure followed by carpopedal spasm and facial muscle twitching. His current laboratory results are as follows. So, steroid dependent arthritis, so steroid immunocompromised, adolescent subcutaneously every 2 weeks. So biological therapy is going on. He developed general tonic-clonic seizure followed by carpopedal spasm and facial muscle twitching. So it may be extracorporeal symptom. Let's see what. Sodium is 134, potassium is 3.2, serum chloride 98, bicarbonate 18, calcium 1.12, magnesium 0.4. So magnesium is low, serum potassium phosphate is low, and serum albumin is 28 gram, just low, gram per liter. Creatinine is little high, and serum urea. So in that case, patient develop, there is a tonic-clonic seizure with carpal spasm and facial twitching. So let's see, and what you are think here you are getting the low magnesium and low phosphate. So it may be this one seizure might be due to hypomagnesemia, and this carpal spasm and facial muscle twitching may be the cause of your extrapyramidal syndrome. Let's see. Which of the following electrolyte abnormality most likely primarily responsible this neurological manifestation? Hypophosphatemia, hypocalcemia, hypomagnesemia, hypokalemia, hyponatremia. So, answer Joydeep is B. B is hypocalcemia. Okay. Anyone? So hypocalcemia, not hypomagnesemia. Magnesium is just 2.4. Calcium is 1.12. It's just lower than the your. So let's see. क्या बोलता है? Hypomagnesemia is the answer. The presentation of this gentleman strongly indicated that severe hypomagnesemia is a primary electrolyte derangement responsible for his neurological manifestation. Severe low serum magnesium level confirm this diagnosis, understand why this is most likely caused. Let us examine the pathophysiology of the clinical context in detail. So magnesium is a crucial cofactor for different enzyme involving adenosine triphosphate, and this play fundamental role maintaining normal muscular function, regularly and regulating the ion channel and neurotransmitter. When the magnesium falls significantly, excitability reduce, inhibition of your NMDA receptor and altered calcium hemostasis. And this gentleman has multiple risk factors to create perfect storm, severe magnesium depletion. One is due to the short bowel syndrome, and other is the enterocutaneous fistula causing magnesium loss through gastrointestinal secretion, and long-term total parenteral nutrition dependency can lead to magnesium depletion if replacement not given. And clinical manifestation of hypomagnesemia is essential maintaining vas. Just a minute. তথাগত. Good evening, sir. Good evening. Mohammed Rabiul Haq. Yes, Mohammed Rabiul Haq, Asfaq's relative. So remember, when there is a hypomagnesemia, if you not correct the hypomagnesemia, it also will not be, you will not be able to correct the hypokalemia. So it may cause the refractory hypokalemia, which ultimately produce the arrhythmia. And so hypomagnesemia is one of the important and the neglected uh, things in the ICU. Why not hypophosphatemia? The hypophosphatemia typically manifests different symptoms like weakness, respiratory muscle dysfunction, and also rhabdomyolysis, severe cases rhabdomyolysis. While confusion can occur, hypophosphatemia rarely present with seizure. So hypophosphatemia will not do seizure as a primary manifestation. So hypophosphatemia in case likely secondary to prove nutrition and total parenteral nutrition deficiency. Hypocalcemia, hypocalcemia, why not hypocalcemia? Because hypocalcemia can cause tetany and seizure, yes. This is typically occur much lower calcium level. Moreover, in this case, hypocalcemia is likely functional and secondary to hypomagnesemia. Hypomagnesemia required for optimal parathyroid hormone secretion and end organ response. Without adequate magnesium level, calcium homeostasis cannot be restored, and calcium supplement with calcium supplement alone. So hypokalemia is not there much, and hyponatremia also is not there much there. Now coming to your question number 4. 20-year-old lady patient to the emergency department with complaint of progressive lethargy, dizziness, generalized weakness following 3-day hiking trip in warm weather. Okay. His past medical history include type 1 diabetes mellitus diagnosed at 12 years, Hashimoto thyroiditis, levothyroxine 125, recurrent episode of oral candidiasis, she take insulin 24 unit and insulin aspart after with meal, and her blood pressure is low, heart rate is high, respiratory rate 22. Despite receiving 3 liters of intravenous crystalloid over 2 hours, her blood pressure is remained low, is appeared deeply pigmented and particularly pumercous and buccal mucosa. So by this step, what the question is indicating, anybody can switch on, unmute yourself, and you can tell. So what we are dealing with. So in your EDIC exam, it is very important before going to the details, you should know that what you are dealing with, your diagnosis made by the STEM. So you will understand what they are asking about.
Sir, this could be adrenocortical insufficiency.
Yes, yes, very good. So the because it is given the hypotension, and if you see that they are given the pigmentation, and they have given the report where you will see the sodium is low, potassium is high, and serum cortisol they have given. Yes, serum cortisol they have given, which is low, and ACTH is high. Now you tell me what is the commonest cause. It is the your it is the addition disease. You are right. So primary or secondary? Serum cortisol level and the ACTH level. Why they have given two? So now, question is one of the following combination of clinical and biochemical feature most common diagnosis primary additional insufficiency in this lady. So here it is said that primary addition disease, but sometimes question asks the primary or secondary. If the primary means it is due to the deficiency cortisol from the medullary level of adrenal gland, and if it is secondary, then it is due to hypopituitarism, where the ACTH also be low. Okay. So that's why they have given the ACTH level. Recently, I got one patient who got admitted under me with a very the vague complaint of weakness, but severe hypotension. The sodium was not very low, but is around 130, and potassium was a little higher side, 5.4 is like that, and there is a palmar crease. And when we evaluated the cause, this is a primary cortisol, and this is due to adrenal histoplasma. After doing the PET CT, we found that there is nothing related to the carcinoma and all. Then we do the CT guided biopsy, and biopsy showing that it is a histoplasma. So histoplasma sometime causes the primary addition disease. So the question is the combination of clinical and biochemical feature most consistent diagnosis of primary refractory hyponatremia and hyperkalemia, hypokalemia and metabolic acidosis, fluid responsiveness. So what is your uh, answer? A, A, yeah, let's see. So refractory hyponatremia and hyperkalemia, and also it may ask they can give the answer of regarding your ACTH level, on the ACTH level also in. So addition disease, you know about cortisol replacement important ADH and diagnosis clinical consultation. So auto, so hyperpigmentation is due to the elevated ACTH and volume refractory hypotension, because cortisol deficiency causes the insensitivity of the your catecholamine receptor and markedly level low cortisol primary adenine. You remember, if this is this line also can be a your one option if they given that it is primary or secondary. Now coming to your 19-year-old lady presented emergency department on 24-hour history of progressive worsening worsening holocranial headache, photophobia, neck stiffness. Her symptom being low-grade fever with mild headache, but over the past 4 hours has become increasingly confused, has been noted her excessive urination, approximately 300 ml per hour, clear urine, her past medical history. Her past medical history include mild asthma treated with salbutamol inhaler. His blood pressure is 128/82 normal. Heart rate is little higher side, respiratory rate is near normal, temperature rate is high, Glasgow Coma scale is 14 by 15. On examination, alert, appeared drowsy, delayed response on the questions is negative stiffness, but no focal neurological deficit, Carnick and Bardisky sign are positive. So you are dealing with meningitis. Let's see what investigation report given. So WBC count is high, mainly neutrophilic, and serum sodium is also higher side. Potassium, urea, creatinine is more or less normal. CRP is high. Serum prolactin is high. So meningitis, probably it is a bacterial meningitis. Blood culture said chest radiographs clear for lung field. So which one of the following most appropriate step in next management? Obtain CT, collect CSF, combine broad spectrum antibiotic, obtain include osmolality, starch dexamethasone. So what will be the answer here? Which is the best choice? Bilal is saying that C, combined broad spectrum antibiotic. Anybody differ with him? No. Okay. Yes, I think Bilal is right because it is a bacterial meningitis. You have to start antibiotic as early as possible. Yes, you have to keep do CT, you have to do CSF study, but because of this is bacterial meningitis and already presence of polyuria and hypernatremia causing the cerebral diabetic insipidus, and this is the correct answer. And dexamethasone, although dexamethasone has no role of bacterial metabolism, but it should be given just before the first dose of antibiotic, not in isolation, waiting imaging while giving only steroid would delay the crucial antibiotic therapy, potentially worsen outcome. So next question. 63-year-old lady presented emergency department after experiencing an explosive occipital headache while is performing yoga, followed by syncope and prolonged post-ictal confusion. Her past medical history include essential hypertension, chronic obstructive pulmonary disease, osteoporosis, hypothyroidism, 45 packed year smoking history. Her current medication include amlodipine 10 milligram once daily, Ramipril 5 milligram once daily, levothyroxine 125 milligram once daily, tiotropium 18 microgram inhaler once daily, alendronic acid 70 milligram once weekly. Upon presentation, her blood pressure is higher side 168 by 92, heart rate 92, respiratory rate 18, temperature is 99, oxygen saturation room air 94, Glasgow Coma scale 14, non-contrast computed CT revealed diffuse subarachnoid hemorrhage, significant cisternal blood, and the early hydrocephalus. Okay. And CT angiography demonstrates 7 mm left middle cerebral artery aneurysm at the M1 M2 junction with daughter sac. The neurosurgical team placed the external vascular drain and targeting intracranial pressure below 20. Okay. On 7-day hospitalization, developed new expressive aphasia and right-sided facial weakness. Transcranial Doppler show elevated mean flow velocity and left middle cerebral artery. So probably spasm is going on. The urine output over last 3 hours is 118 ml and serum sodium decreased 138 to 32. So serum sodium 132 lower side, potassium okay, chloride okay, bicarbonate is also okay, bar nitrogen is okay, creatinine is okay, Osmolality, yes, osmolality 272 to serum osmolality low, urine pot sodium 85 high, urine osmolality is high, it's normal. Serum cortisol is normal. So you are dealing with the primary diagnosis. Hmm? So
SAH causing diabetes insipidus.
yeah,
Cerebral salt.
why not SIAD? What is the difference between SIAD and uh, cerebral salt wasting syndrome?
Euvolemia.
Yeah. So here anything is one one is euvolemia, other is serum osmolality and the urine osmolality difference. No? So let's see. The continuous maintenance intravenous fluid normal watch urine output administration. Okay, discontinue. So what will be your answer? Cerebral salt wasting syndrome. Okay. What will be your answer? How many of you given the E or sorry, E will F? So continuous maintenance intervention normal saline matching urine output administration to 3% hypertonic saline 30 minutes. So cerebral salt wasting syndrome because here the osmolality, urine osmolality is perfect. If the urine osmolality high and the serum osmolality low, and along with the urine spot sodium high, then it could be CR. So, and also salt wasting syndrome that your urine osmolality little bit on lower side, but here it is normal given anyway. So in it is I think it is not CR because of that. Okay, and the cerebral salt wasting syndrome is just you have to keep giving fluid and maintain the sodium level. And the desmospacin approach would be appropriate diabetic insipidus, but it is contraindicated in cerebral salt wasting syndrome. Desmospacin would be increased free water retention, potentially worsen the hyponatremia, while fluid restriction would be exacerbate volume depletion. And fludrocortisone, although mineralocorticoid therapy, fludrocortisone can be useful in chronic management of cerebral salt wasting syndrome. It is not most appropriate initial intervention when acute volume and sodium depletion is needed. So first thing is you replace the fluid, maintain the chloride, sodium level, and third thing is the start fluorocortisone. Now coming to next question. 72-year-old gentleman, weight 80 kgs, with long-standing history of hypertension control with amlodipine, being prostatic hyperplasia managed with tamsulosin 0.4 milligram at bedtime, was admitted with intensive care unit following prolonged and complicated surgical procedure involving partial colectomy and liver resection for local invasive colon adenocarcinoma. His coronary artery disease is managed with bisoprolol, low-dose aspirin daily. He has no history of chronic kidney disease or diabetes mellitus. During surgery, which is a prolonged surgery, 6 hour surgery, he experienced significant hemorrhage during and requiring transfusion of 5 unit Paxil 2 liters of crystalloid fluid. Post-operatively, the indwelling urinary catheter was inserted after initial difficulty due to prostatic enlargement, leading to minimal hematuria. On intensive care unit admission at 1 p.m., his vital sign, including blood pressure, is 118/75, heart rate 82 per minute, respiratory rate is 18 beat per minute, oxygen saturation is 99% with 3-liter nasal cannula, and temperature is 99.6. Over next 18 hours, his abdominal drain produced 750 ml significant serosanguinous fluid, and his urine output steadily declined from 70 ml to 15 ml per hour, 10 ml per hour, or 5 ml per hour, consecutive 3-hour interval. And by 7 a.m. following morning, the vital sign deteriorate, blood pressure is low, heart rate is 110, oxygen saturation 98%, temperature is nasal cannula, and temperature is 100 by 4 degree Fahrenheit. So it is you are dealing with a hemorrhagic shock, post-operative hemorrhagic shock. So hemoglobin is initial hemoglobin is not given, no. So hemoglobin is 7.8, count is 14.8, platelet, sodium, potassium is okay, creatinine is little higher side, barn is little higher side, lactate is high, urine sodium is 18, okay, and urine osmolality is higher side. So what urine analysis? So amber color urine, specific cavity is no evidence of red blood cell and protein, no cast, visible microscopy, focus, abdominal ultrasound reveal moderate amount of free intraperitoneal fluid, no evidence of hydronephrosis and bladder distension. So, which one of the following most likely in this gentleman? So, what is happening here? Diagnosis. Anyone can unmute and volunteer, please. Which one of the following finding would least likely in this gentleman? Serum burn, creatinine ratio, fractional excretion sodium more than 3%, high urine specific cavity, urine osmolality less than 3, and RBC cast in urine microscopy. So what is your initial diagnosis here? So it is
Renal AKI.
pre-renal azotemia. So whatever may be the cause is a pre-renal azotemia, AKI, yes, pre-renal azotemia. Now,
B.
pre-renal azotemia, these all are the features of pre-renal azotemia except RBC cast in urine microscopy, because RBC cast is found in acute nephritis. So RBC cast on urine microscopy, it is not normally found in AKI. And one creatinine ratio, usually in AKI, it will be ratio 10, more than 10 is to 1. And your sodium fraction also will be more than 1 is the diagnostic. And obviously, the specific gravity of the kidney, it is depend upon the causes, and osmolality is also another marker for ATN. Now coming to your question number 8. 73-year-old gentleman, weight is 78 kg, with history of hypertension, managed with losartan 50 milligram once daily, and been prostatic hyperplasia treated with finasteride 5 milligram daily, was admitted into ICU following emergency exploratory laparotomy, bowel perforation, and surgery reveals significant intra-abdominal contamination and require resection of affected bowel segment. And he also history of coronary artery disease managed with atenolol, clopidogrel, surgical procedures prolonged, lasting approximately 7 hours, complicated by hemorrhaging, requiring 4 unit blood transfusion, 3 liter crystalloid fluid, post-operatively, central venous catheter, indwelling urinary catheter were inserted, associated with initial difficulty due to prostatic enlargement. Okay. On admission in the ICU, 10 p.m. vital sign include blood pressure is 122 by 76, heart rate 88 beat per minute, respiratory rate is normal, oxygen saturation 3 liter maintaining 97%, temperature is normal. Over the course of night, his abdominal drain produced hemorrhagic fluid 850 ml, his urine output declined 60 ml to anuric. Subsequently, 6 hours by 6 a.m. following morning, his vital sign also deteriorating. The blood pressure is low, tachycardia, tachypnea, and oxygen saturation maintaining, and temperature is there. So investigation revealed hemoglobin is low, WBC count reactionary high, platelet okay, sodium okay, potassium, creatinine is little high, burn is little high, serum lactate is high, and urine sodium is low, and the urine osmolality is. So again, the question is urine analysis. So dark yellow urine, specific cavity is more 1.032, no visible protein, red blood cell, no cast. On abdominal ultrasounds of moderate ascites, no evidence of bladder distension or hydronephrosis. The senior house physician transfused patient with 3 unit packed blood cell and 2 unit fresh frozen plasma. Surgical team regarding the ongoing hemorrhage. Gentleman was taken back to operation theater where bleeding vessel was identified and ligated. During this procedure, he received 1.5 liter crystalloid, 2 unit fresh frozen plasma, 2 unit platelet. Despite hemodynamic stability following 12 hours, gentleman remained anuric, have no improvement of the renal function. Following intervention will benefit this gentleman. Administration of furosemide, improve urine output, urgent initiation renal replacement therapy, intravenous infusion of low dose dopamine, enhance renal perfusion, administration of mannitol, promote osmotic diuretics, none of the above. Yes. So, furosemide, anybody for furosemide? Administration furosemide, okay, which usually we do, but let's see. None of the above. This gentleman have acute kidney injury, likely progressed to acute tubular necrosis due to prolonged ischemia and hemorrhagic shock. Treatment of acute tubular necrosis primarily supportive, focusing on maintain adequate renal perfusion and hemodynamic stability. Renal replacement therapy indicated case of fluid overload, hyperkalemia, and severe metabolic acidosis, uremia. While diuretics such furosemide or mannitol is transiently increase urine output in some patients, they do not improve renal recovery outcome established in acute tubular necrosis. Similarly, low-dose dopamine has not been shown improve in functional clinical outcome in this setting. So furosemide only it is indicated if you do the fluid resuscitation, and in ATN your main aim will be hemodynamic stability and the fluid adequate fluid volume, maintain the adequate fluid volume. Furosemide sometimes it's cause more harm to the kidney, and renal replacement therapy, maybe this patient landed up to the need for the CRRT, but first you have to resuscitate the fluid and you have to maintain the blood pressure. After still then there is no urine output, then you can go for the CRRT mode because hypotensive. So CRRT is not first choice. And intravenous infusion, low-dose albumin, low-dose dopamine already has been explained, and administration mannitol promoting osmotic diabetes. Because here the problem is the fluid. Anuric is due to hypovolemia, perirenal azotemia again. So fluid replacement, maintaining BP is the first priority. Now coming to the second, uh, today I will talk up to the 10 number of question. And
Yes, sir, I'm here.
Padma, you have to give another 1 day session. Probably it is the afternoon session will be better. If you can give tomorrow, I have no problem. 3 p.m. to 4 p.m. to
Okay,
complete this other question. Today I will complete till 10. Okay. So this is the second last question. Is 62-year-old gentleman admitted to intensive care unit with septic shock secondary to pneumonia. His past medical history include hypertension, type 2 diabetes mellitus, chronic kidney disease, and congestive heart failure with reduced ejection fraction. The current medication include Remipil 5 milligram once daily, metformin 1000 milligram twice daily, carvedilol 12.5 milligram twice daily, furosemide 40 milligram once daily. On examination, he has a blood pressure is low despite being noradrenaline zero point 0.5 microgram per kg per minute. Heart rate is 122 beat per minute. Respiratory rate is 28 beat per minute. Temperature is high. Oxygen saturation 92% on 60% FiO2. Neurological examination, renal sluggish pupillary reaction. Glasgow Coma Scale 12 due to concern about neurological deterioration. Extraventricular drain was placed, so intracranial pressure is 22 mmHg. So pneumonia followed by there is a sepsis. Let's see, the hemoglobin is 9.2, WBC count is 22, and platelet is still okay. Sodium is okay, potassium little higher side, serum urea high, creatinine high. So AKI is there, lactate is high due to hypotension, septic shock, and pH is metabolic acidosis, base X is this. CT so mild cerebral edema, early sign of hydrocephalus, prompting placement of extraventricular drain. Medical team discussing option of the renal replacement therapy. So which one of the following statement regarding the continuous renal replacement therapy compare with intermittent hemodialysis? CRRT provides superior mobilization of opportunity due to continuous in nature. CRRT demonstrate reduced efficiency in metabolic control of fluid removal. CRRT. So, which is most accurate clinical scenario? Okay. CRRT is higher risk increasing intracranial pressure compared to intermittent hemodialysis. CRRT offer better hemodynamic stability, cerebral perfusion pressure maintained, and CRRT require low anticoagulant requirement. So, which one is the correct answer here?
D.
D. CRRT offer better hemodynamic stability and cerebral perfusion. Yes. CRRT require lower anticoagulant? No, because it is an extracorporeal therapy, so require high. And because blood flow is low, so you need a high anticoagulant. CRRT pose high risk of increasing intracranial pressure compared intermittent? No. Demonstrate reduce efficacy in metabolic control and fluid removal, reduce efficacy of metabolic control and yeah. So B, why not B? Hmm, let's see. So D is the answer, obviously. Why not B? Because the it demonstrate reduce efficacy. No, it's at a good efficacy of metabolic control and also fluid removal, but the fluid removal is slower than your intermittent or SLED. So CRRT give the better hemodynamic stability and better your neurological outcome at that it prevent the osmotic what I can the CRRT guarded solute removal prevent the osmotic shift towards cerebral edema. Okay. So CRRT demonstrate reduced efficacy metabolism. This represent common misconception about efficacy of continuous versus intermittent. While continuous renal replacement therapy does remove solute and slower rate per hour compared to intermittent, but within 24 hours, if you see that it has a good efficacy. Now coming to the last question, 55-year-old gentleman admitted to intensive care unit, severe metabolic acidosis, sign of uremia, including confusion and nausea. He has history of hypertension, type 2 diabetes mellitus, ischemic heart disease with prior myocardial infarction 5 years ago and underwent coronary bypass grafting 3 years ago. Current medication include metformin, losartan, atorvastatin, aspirin. On examination, his blood pressure is okay, heart rate is okay, respiratory rate is okay, and temperature also okay, appear drowsy but erosible, has bilateral lower limb edema existing, extending to knee. So ICU with metabolic acidosis, sign of uremia, including confusion and nausea. So maybe this patient suffering for uremic encephalopathy and uremia. So urea is high, creatinine is also high, potassium is also high, and bicarbonate is low, arterial pH metabolic acidosis, and you see the albumin is just near normal, calcium is little low, phosphate is little higher side. So it's kind of uremia. Imaging study revealed the bilateral small kidney, increased cortical echogenicity, renal ultrasound, chronic kidney disease, gentleman comments, renal replacement therapy. Okay. Which one of the following technique does hemodialysis employ primarily to solute clearance? Osmosis, diffusion, convection, diffuse ion, convection ion, ultrafiltration. So it is the question about the modality of solute, how you remove the solute by convection or diffusion and convection. B, both diffusion and convection. Yes. Any difference of opinion? Okay. So let's see. Yes, both diffusion and convection. So modern hemodialysis employ both diffusion and convection as it is primary mechanism of solute clearance, making it most complete and accurate answer. Let us examine how this process work together in hemodialysis. In diffusion hemodialysis involve movement of solid across the semi-permeable membrane, and convection create a pressure. When in convection when the solution is going and it carries the solute. Its convection act on the pressure gradient and diffusion acts on the concentration gradient. So in modern hemodialysis, we use the both diffusion and convection. And ultrafiltration is specially referred to process water removal, and only convection is effective only middle-sized molecule, but not only mechanism used in modern hemodialysis. And also similarly, only diffusion is not used. Though diffusion also remove the different size of molecule. Osmosis is not in the part of your dialysis mechanism. So tomorrow I will start with question number 11. Fatma is here.
Yes, sir.
So Fatma, tomorrow, if I do tomorrow at 3 to 4 p.m., student, you have any problem? I don't know the situation, your work pressure. Usually, it is very, I'm sorry to say, I'm little selfish. It is easy to take for me, take classes at 3 to 4. That's why I'm asking. So it's okay for you all. You can unmute and you can give your opinion.
Any
Okay.
aspirants facing any problem or have any question, you can
So
communicate.
everybody says that yes, okay. So tomorrow we will again we will come and sit at 3 to 4 p.m. And I will take one special class on CRRT because CRRT one of the crucial part in EDIC exam. Nowadays they give lot of question on your organ support and troubleshooting. So it's in your practical exam also, part two, you will get a lot of question on the CRRT, you will get lot of question on ventilator, you will get lot of question on ECMO therapy, you will get lot of question on your left ventricular devices. So in renal system, you have to know everything about the RRT. The question can come in the indication on methodology, on principle, CRRT prescription writing, right dose, and also rhabdomyolysis. It is a part of renal. So they will ask about the electrolyte, the type of electrolyte imbalance, on the management of rhabdomyolysis, and the pathophysiology of rhabdomyolysis. You will found the question. So tomorrow I will take rest of the things. Then I will take one special class in this month, end of this month, on CRRT. The 360 degree about the CRRT is indication, it principle, it prescription, everything. Okay. So it will help you for your in your exam, both part one and part two. Fatma, that's
So I'm scheduling a class for tomorrow at 3 p.m.
okay.
Thank you, sir.